Hello, I'm Hana Nagel, and in my talk, A Chair in a City, I'll be sharing some thoughts about how we can improve diabetes services and the design of technical products by designing for context. Some background about me and why I feel passionate about this topic. I'm a type 1 diabetic, living with diabetes for the last 14 years. And I also have a multi-ethnic background, so I often think about and apply intersectionality to my work. And lastly, I'm a service designer and a product researcher focused on large-scale technology systems, from AI enterprise software to federal design projects. So as part of my professional practice, I am focused on how to deliver the best designs that account for a wide range of user contexts. My talk today is going to cover 3 points that I think are helpful when thinking about how to improve the design of diabetes healthcare services and medical technology. So I'll start by exploring how we can better understand context through socio-technical systems. So how taking a systems level view can help us to identify the barriers or opportunities for change and can improve the way we design for diabetes healthcare outcomes. Next, I'll be covering how some of those barriers came to be embedded in our institutions, including healthcare, and created biased data and biased service delivery, and how a focus on place rather than race can help inform more equitable design by grappling with problematic data sets and unequal access to technology resources. Lastly, I will share some thoughts on what questions we can ask at different stages of service and technology design to more closely interrogate the context, data, and team makeup that informs equitable design processes. So when thinking about designing for context, I often draw inspiration from the design philosophy behind one of my favorite chairs, the Womb Chair by Aaron Saarinen. It's an icon of mid-century modern design, and the design brief for this chair instructed the designer to create a comfortable chair that would be just as appropriate for private relaxing spaces like a living room to public high-stress spaces like an airport lounge. This chair reflects Saarinen's design philosophy. Always design a thing by considering it in its next larger context. A chair in a room in a house in an environment, and an environment in a city plan. And so I'd like us to keep this image in mind as we explore how different contexts interact with each other in a system, and how this shapes the outcome of what we design. A helpful lens to understand context is what we can call the socio-technical system. So modeling out context this way allows us to take a broader view of the different contexts in both a social system and a technical system, and to consider how social structures, roles, and rights interact with and inform the design of systems that involve people and technology. So in the social system, we have structure, which can be organizations, laws, and regulations, as well as the individual, which can include cognitive and other social systems. And on the technical side, we have technology, which includes software, hardware, facilities, and information systems, as well as tasks, which can be work allocated both to machines or work that should be performed by humans. Often when we design services or technology for diabetes, we focus on one element of interactions, how a piece of technology can help execute a task or how an individual uses the technology. When we do this, we focus only on the chair or the room or the house, rather than the overall broader context and how all the pieces interact with each other. We can overlook or misunderstand how human, social, and organizational factors affect the outcomes we are designing for. We can also miss structural barriers that are preventing the changes we're designing for. Thinking about the broader context of interacting factors, or how the chair fits into a city, can help us think about what elements of the socio-technical system are contributing to health outcomes for historically excluded communities, and what we need to focus on in order to design for change. Social determinants of health, such as safe housing, job opportunities, and access to nutritious foods and physical activity, contribute to wide health disparities and inequities. For example, people who don't live in safe neighborhoods are less likely to exercise outside, and people who don't have access to grocery stores with healthy foods are less likely to have good nutrition. This raises the risk of health conditions like diabetes. Let's take an example from the CDC's page on type 2 diabetes, which states that people of certain racial and ethnic groups are more likely to develop prediabetes and type 2 diabetes, including African Americans, Hispanic, and Latino Americans. According to the CDC, there are several factors for this. A genetic component that increases BIPOC's chance of developing type 2 diabetes, cultural foods that are higher in fat and calories, and social pressure to overeat, as well as higher rates of obesity and a tendency to be less physically active. Now, if we were to design a digital app or a piece of medical technology or healthcare service to solve this problem, the way that the CDC describes it, we would be focused on changing behaviors around eating and exercise habits, and perhaps getting frustrated when our patients did not follow recommendations and marking them as non-compliant patients. I want to point out CDC's problematic use of the word race, and special thanks for this slide goes to Alba Villamil, a user researcher whose work explores the intersection of design and social impact. So race is the assumption that we can divide individuals into groups based on their physical characteristics or genotype, and that those groups have meaningful differences. But Latinx refers to people born in or with ancestors from Latin America, a continent with 33 countries. And Hispanic, which broadly refers to folks from Spanish-speaking countries, including Latin America and Spain, which is a country on a different continent. African American is a term which describes folks with ancestry rooted in Africa, a continent with 54 countries. So race is a social category that captures differential access to power and desirable resources in society. Thinking that folks of color, with roots from almost 90 different countries, are all genetically predisposed to diabetes ignores the social determinants of health. It focuses on the chair and ignores the city. Zip code or place is the greatest health determinant, not race. Throughout the history of the United States, folks from historically excluded communities, such as Black and Latinx folks, have received inferior treatment in major societal institutions. Medical care is no exception. In order to understand and design for the broader context of social determinants of diabetic health, we need to grapple with systemic racism. In North America, but especially in the US, access to resources, including medical care and devices, is shaped by a history of housing discrimination. In 1934, the federal government created the Federal Housing Administration, or the FHA, to restore the housing market after the Great Depression and provide Americans with federally guaranteed loans. Eligibility for mortgages was determined by which zone you lived in. To make it easy for lenders to determine eligibility criteria, the FHA created these color-coded maps of major American cities. Green zones were desirable for lending purposes. Blue zones were eligible for lending but were less desirable. Yellow indicated a declining neighborhood, and red was reserved for hazardous neighborhoods. What made a neighborhood hazardous? The underwriting manual of the FHA stated that incompatible racial groups should not be permitted to live in the same communities. So neighborhoods with Black and Latinx residents were deemed ineligible for FHA backing. The FHA's mortgage lending system essentially enforced segregation through exclusionary zoning laws, prohibiting the sale of property to folks of color. Now these community zones, biased by design, became entrenched in the American socio-political system. Structural racism is not a force majeure. It is not a naturally occurring phenomenon. It is biased by design and reflects the successful implementation of social policy. The healthcare systems, alongside technical systems, legislative systems, etc., have been shaped by bias. So place, not race, means acknowledging that the design of healthcare services and medical technology may generate or reproduce inequality and oppression. When designing services or technology, it's critical that we also grapple with the social and historical context of how our current data sets came to be and how that bias became embedded in the data. An example of this can be seen in an algorithm widely used in US hospitals to allocate healthcare to patients, which was found to systemically discriminate against Black people. Folks who self-identified as Black were generally assigned lower risk scores than equally sick white people. As a result, Black patients were less likely to be referred to programs that provided more personalized care, resulting in lowered health outcomes for Black folks when compared to white folks with the same health profiles. Acknowledging structural racism's impact on health outcomes is critical to designing for equity. Fixing biases in healthcare, including algorithmic biases, is a complicated task, and one place to start is by understanding that social and historical context of healthcare data sets. So when being intentional about designing for equity, we need to take a wide view of the current context and to understand the past context of the problem space. Now I want to apply what we've discussed to see how this can change our approach to design. But before we talk about what we want to do, let's clarify what we want to avoid. We want to avoid racist designs that facilitate racial inequality or oppression. We can do this by considering a range of factors that are contributing to social inequality. So for example, cognitive factors. How do users make sense of and adapt to their personal situation? How are users' unequal environments shaping their access and experience of a design? How do users of a design purposely exclude, control, or discriminate against other users? How do design elements and organizational policies perhaps disadvantage certain users? And how do large-scale societal patterns and changes create social inequality? So let's return to this example from the CDC and apply our view of context to rethink the problem framing. Problem statements like, how can we encourage BIPOC patients to cook healthier food, implicitly frame the project around individual failure. This is problematic because this framing downplays the systemic barriers that BIPOC folks experience. And it also disregards how these barriers limit people's choices and impact their decision-making. To design more equitable healthcare services and medical technologies, we need to zoom out from our users, the chair, and seek to understand how other elements in the socio-technical system are impacting our users' success in interacting with our designs and achieving their goals. So when designing for equity, instead of having this focus on racial contribution, genetic contribution, we can instead think about place. So how do large-scale societal changes create the social inequality that can lead to disparate or worse healthcare outcomes for the communities that we're designing for? Instead of focusing on alleged cultural elements, we can instead focus on cognitive factors. So how are users making sense of and adapting to their personal situations? And how does that impact choices around food and nutrition? Instead of focusing on a tendency to be less physically active, let's think about the environment that our users live in and the kind of barriers that they might have in terms of increasing physical activity. So how do our users' unequal environments shape their choices and experiences around physical activity and exercise? We can divide our process into this kind of flow. So at the first step, when we are designing for equity in healthcare services or medical technologies, and we're thinking about the outcome that we want to design for, we need to think about systems. So what systemic barriers are in play, and how do those barriers shape the choices that our users are making? The next is to consider the data that we're using to inform and build our designs. We need to address computational bias in the software or the data sets. And we also need to advocate for standardized data to understand and remove bias in healthcare service or tech design. And lastly, we need to increase diversity of healthcare service providers and designers. Homogeneity in both the design and healthcare industry is a problem because it makes us more susceptible to biases. So increasing the diversity of the teams who are creating the services or designing or coding the software will lead to better health outcomes for the diabetic community. To close, I want to share another quote from a different chair designer, Charles Ames, who said the mark of a designer is a willing embrace of constraints, and that without constraints, design cannot happen. The best design, a precision medical device or an emergency shelter for disaster victims, is often carried out within quite severe constraints. So in order to design for equity in diabetes healthcare services and technology, we must acknowledge and grapple with the systemic constraints that are impacting outcomes. Then we can move forward together, designing with context in mind and for positive change. Thank you for your time today. I'm looking forward to hearing your thoughts, and if you'd like to connect with me after, you can use the Twitter bio.